Good morning, everyone, and welcome to our second webinar in our breakfast series. We're currently just holding for a few more attendees to join us, and then we'll get cracking with our lineup of speakers today. So grab yourselves a nice warm drink and maybe a cheeky pastry or something to keep you going for our breakfast series. So those of you that have just joined us, we're just waiting for a few more minutes, just for a few people just to get through the technological hoops of joining the webinar, and we'll get started with our first speaker in a couple of minutes. And those of you that are just joining us, we're just waiting a minute or so for the last couple of attendees and the audience members to join us, and then we will get started very, very shortly. Right, good morning, everybody. It's just gone 10 o'clock in the morning, and welcome to our second webinar of our TRIPOM breakfast series, where we're discussing perioperative care updates and the challenges and solutions in the post or COVID era, should I say. Thank you for joining us on a Saturday morning. I hope you've got a nice hot beverage and cheeky pastry to enjoy while we have our three esteemed speakers give us some really interesting lectures today. So today we're going to move along the patient journey and really focus on the intraoperative changes we may see or challenges we see in this COVID era. And as TRIPOM, both myself, Irwin, and Katie, we're very excited to welcome our three speakers who are joining us from far afield as Hong Kong and also within the UK. And before I hand over to our first speaker, just a bit of housekeeping. Those of you that have used GoToWebinar before, you'll know there's a little question mark at the top corner. If you click on that, you can submit your questions throughout the talks, and then Katie Samuel will be sifting through those questions so that we can ask our speakers questions from the audience at the end of their talks. So our first speaker is Prof. Irwin. He's joining us on his Saturday evening all the way from Hong Kong. Prof. Irwin is Chief of Services Anaesthesia and Critical Care at Clinical Hospital. He's the past president of the Society of Anaesthetists of Hong Kong and of the Hong Kong College of Anaesthesiology. He's also a senior editor of the Hong Kong Medical Journal. His research interests include intravenous anaesthesia, pharmacology, enhanced recovery, and organ preconditioning. And I'll now hand over to Prof. Irwin.
Thank you very much, Aaron, and thanks very much to Katie and Johnny as well for giving me the opportunity to be involved with this. TRIPOM is certainly a great idea, and it's very encouraging to see so many trainees interested in this area. So that bodes very well for the future. And so this afternoon, I'm going to talk about our own experience. I guess a lot of our experience will be very similar to yours, so we'll go through that. Maybe some slight differences, I think, with the initial approach and the sort of culture of the people that live here vis-a-vis this disease with their previous experience with other coronaviruses. And you can see there's the Twitter and chief in the background there. I'm going to come back to him towards the end for a little bit of light relief. He's probably as much responsible for the spread of this illness as anybody. So, I mean, this is the most incredible and unprecedented global pandemic. I think we've been fairly lucky in the world that we haven't had anything like this for maybe over 100 years. Pandemics actually were relatively common actually up until about 100 years ago, I think. Then with better social conditions, hygiene, housing, the advent of antibiotics and vaccination, so on, these kind of virtually disappeared. There are obviously pockets of illnesses occurred here and there, but this is really quite incredible. Now we're talking about at least probably around 30 million confirmed cases and about 1 million or so deaths that we know of. If we look at individual countries, I mean, my country, I live in Hong Kong. We've actually, I think if you look at probably where you're living, most of you, I think, are in the UK. We would certainly look like we've got off fairly lightly here. We only have around 5,000 confirmed cases. Most of them have got better. Currently, only about 200 patients hospitalised. In our own intensive care unit, we only have 2 patients at the moment, and neither of them are requiring ventilation. We've had about 100 deaths or so. So this is a website which our government updates every day and gives statistics about where cases have occurred and so on and so forth. Recently, they have undertaken mass testing of Hong Kong citizens. They've now tested it. We have a population of around 6 or 7 million people. They've tested around 2 million or so. They only actually found 20 patients, but with COVID. But in fact, these patients were actually relatively asymptomatic, so that they could be important for spread. We've gone through essentially 3 waves of illness. The very first one was wave in January. And one of the things I want to kind of mention, I think it's a little bit different for us, and the relevance of this is that, as you probably know, we had a very serious coronavirus outbreak in 2003, so 17 years ago, called SARS. And SARS originated again in China, probably originated in a fairly similar way. SARS was probably, well, certainly was less infectious than COVID, but because of our proximity with China, we were impacted very early with this. And this is a kind of infographic of some of the cases. You can see that this was really very localized to the Asian region and didn't really impact most sort of European, Western, North American countries. Canada a little bit, because a lot of Hong Kong people in Vancouver and Toronto, so that they were sort of little pockets of infection there. But the thing about SARS was that SARS actually has, I think, created a kind of culture here where people sort of witnessed this very serious illness. In fact, the mortality from this was much higher than with COVID. In Hong Kong, the mortality was about 17%, and there were quite a few healthcare workers who got infected, and actually, unfortunately, quite a few that died. So whenever the current infection broke out, people took this really very, very seriously right from the start. I think that may be a key difference as to what happened, certainly in Europe. I remember, I'll talk about that a little bit in a minute, but these are actually slides taken from around the time of SARS. You can see that we were used to using PPE and so on. This was kind of quite normal for us. And ever since that, there have been a lot of public health information about preventing the spread of these respiratory type illnesses. So this obviously is influenza, but in fact, a lot of it was really because of SARS that this came about. Interestingly, at the time when SARS kind of occurred around early part of 2003, around January, we have you may know we have a big rugby tournament at the end of March, early April, the Hong Kong Sevens, and they actually allowed the Hong Kong Sevens to go ahead that year. It's interesting in so much as I think if we'd had an illness like COVID that was as infectious as COVID, this could have been a very serious index event that could probably have spread the disease all over the world. So I think in retrospect, it was somewhat foolish to go ahead with that. And this year, obviously, that was cancelled, and travel and so on was banned very quickly. So I think we've taken this, as I say, we've taken this very seriously. I actually looked back to see what we were doing at the time, and we had very clear guidelines about how to manage SARS, and we always were concerned that something like SARS might occur again. Our epidemiologists and microbiologists were very much involved in determining what SARS actually was, the type of coronavirus it was. We got quite a lot of experience with managing the patients, preventing the infection, etc. So we already had a lot of guidelines kind of that were ready to go should something like this occur again. This is just an example of what we had at that time. So, for example, ever since that time, interestingly, we don't use nebulizers. We never have using nebulizers in the OT or the recovery rooms. We're very, very careful about using the Venturi mask, very selective about that, open suctioning, jet ventilation, and so on, because of what happened. So what happened this time? Well, this is January, the end of January 2020, and already China's got about 10,000 cases, and we started to get some early cases in Hong Kong. We had about 12 cases occurring in Hong Kong at that time. So most of the doctors actually wanted Hong Kong to close the border with China at that time because, again, as I say, our epidemiologists and so on here have a huge amount of experience with dealing with this type of illness. And their advice was you should close the border, but for political reasons, and I'm sure you're aware, last year we've had a lot of social unrest in Hong Kong. There's a kind of a bit of a backlash against China within this last couple of years. I feel that the Chinese influence here has become too strong and various things. I don't want to get into that too much, but it was a kind of politically sensitive issue to actually close the border with China. And there was a little bit of delay in that, but then eventually they did that, and we instituted our guidelines quite quickly, actually, as you can see here. So we had our initial emergency response activated just right towards the end of January, and initially we decided we would, because we didn't know too much about the disease. We obviously were seeing, stuff coming from Wuhan. It's kind of funny because the original disease SARS that we had, people here started calling the wars instead of SARS, which was the Wuhan acute respiratory syndrome. But of course, that became very politically incorrect to use that term, so that was soon dropped, and eventually we got COVID. So we had our initial emergency response quite early, and then as we saw the number of cases start to escalate, and as we were actually able to discuss with some of our colleagues in China about what was happening there, then we decided to move to full PPE about a week later. Now, we have actually got a lot of connections with doctors in China, as you would imagine. In fact, I've got about one of my associate professors from Wuhan. I've got several research students from Wuhan and so on. So for some reason, particularly, we had quite strong links with Wuhan, and that we could be able to utilize that to help with this a little bit. So it's very important whenever you initially decide to activate these levels of protection and care that you make sure that the staff are trained properly in how to use it. So we have a number of N95 masks, for example, and we actually do regular fit testing for N95. Again, this is something that we've done ever since the time of SARS. So all of our staff, new staff, they go for fit testing, because there are several different models. You want to make sure that this is the right model to fit your particular face. So I don't know if you guys have gone through fit testing, but it's a fairly rigorous process to make sure, you know, that with movement and normal activities, there's no leak around the mask. It's very, very important if you're going to use these masks properly, obviously. We had videos which we prepared on airway management, how to don and doff PPE. We had infection control staff come around to help educate us on how to be doing this and refresh everybody's memory about it and so on. It's important also to make sure that this is a multidisciplinary, that everybody knows what's going on, everybody knows the role, everybody knows what's going to happen in terms of when we have patients either with the illness or patients that are at risk of having and transmitting the illness, how we're going to protect everybody within the team. So we had a lot of kind of multidisciplinary team discussions ourselves, nursing staff, OTAs, and so on. So again, very important. So at the same time, we decided to scale down our elective services by about a third. And the reason for that I've listed here. The first one is we wanted to conserve the PPE if the number of cases continue to surge, and we can see that certainly the number of cases rising quite rapidly. We needed to create some room for more isolation wards, and we were actually asked to redeploy staff to certain areas where they may be required. So these are things like not just obviously, you know, anesthesia trained doctors can work in emergency medicine or intensive care if called upon because of a fairly similar skill set there, but also to do more routine work in medical isolation wards. So some of our trainees were redeployed to there, and not just us, but you know, surgical trainees and other doctors, excuse me, were redeployed to these areas. And that obviously was going to impact on our ability to do elective surgery, both with surgeons and anaesthetists and so on, not as many available. We set up one designated operating theatre for cases with known COVID infection who were going to require emergency surgery. That includes things like cesarean section. We have a separate area that we normally do cesarean section, but in this case, we obviously use the one operating theatre for all those surgeries. Every year, and as I'm sure similar in other hospitals, we have to overhaul our operating theatres and get the air conditioning systems fixed and things cleaned up and so on and so forth. So rather than waste the time when some of these operating theatres were being shut down, we actually decide to overhaul them. We normally do it around the end of the lunar calendar because the Chinese New Year is a big holiday here. A lot of people take leave and so on, but we decided we may as well use that time to do that, and we did that. Laboratory testing initially was very stretched, so we talked to the microbiologists, and they really said that we couldn't initiate mandatory preoperative COVID screening. You know, so ideally we would want to, you know, all patients coming in for surgery, we want to test them to see if they're infected or not, but it was not implemented. But now actually that with the testing has been ramped up, it is implemented, so we can do that now. We've been able to do that now for patients coming in for elective surgery. Another hospital that I work in, the university is involved in a private hospital, which is sort of public-private partnership thing. They were able to do testing basically because they charged the patients for it. So testing was introduced quite early there, but in our public hospital, we didn't do that until fairly recently. So I guess you'd be interested to know what the impact is on trainees, and it will be interesting to hear what, you know, the impact has been on you, because it's a fairly significant thing here. I mean, we've obviously had a certain reduction in caseload. It's also the fact that there were general recommendations that patients should be managed by more senior doctors, simply because we have a, you know, potential shortage of PPE, and we couldn't necessarily have, you know, a half a dozen people in the operating theatre for things like airway procedures and so on. We've tried not to do that actually, because we also think it's important for them to learn. So we tried not to do that too much. We had this secondment, obviously, which meant that that some of the doctors were redeployed to other areas, and that's obviously going to impact their training. It's going to reduce the training hours. There was some restriction of options for anesthesia, so there are certain types of procedures and so we tried to not do. We were trying to encourage patients to have more regional anesthesia, spinal anesthesia, that type of thing. So we've been careful with that. And then there was less opportunity for managing the airway, that type of thing. I think the impact is probably more on the junior than the senior trainees, because the senior trainees were able to be more involved, and the junior trainees were more likely to be redeployed to the medical wards. There's obviously the psychological stress involved in that. I mean, we actually asked our staff to volunteer. We didn't kind of tell them, look, you've got to go and do this. I think this is important. We were lucky, our staff here very motivated. We didn't have any trouble with this. There were a lot of people who were willing to sort of roll their sleeves up and try and help out. But this is quite a difficult thing for people, you know, especially, you know, you've got a young family or whatever, because during the period of secondment, if you were in intensive care or even in the medical COVID wards or in the emergency departments, they request them to stay in a hotel away from the family during the secondment to reduce the risk of spread to their immediate relatives and friends. And then at the end of their deployment, they then had to go through a 14-day mandatory quarantine period as well. So that's not easy. It's a reasonably nice hotel, quite close, but you know, it's still quite difficult to have to stay there and so on. A lot of our examinations were delayed, postponed. We initially, like others, thought that this might all be over by the spring. So the initial idea obviously was to just sort of put them back and we'll do it a little bit later. But as it's become apparent that that's not going to be the case, we've actually just recently conducted some examinations where we did Zoom vivas with subjects taking the exams, and we have modified our OSCE exams as well to, you know, incorporate the social distancing, patients and that are used in the OSCEs and volunteers who help, all and examiners and the don't call them students, and the trainees are tested for COVID before the exam, and they not allowed into the exam if they have a temperature of more than 37.5 degrees. So it's fairly rigorous in terms of trying to prevent infection spread. This is just a thing we put out at the time to explain what was happening with the deployment of our staff to the COVID wards, and they were working 12-hour shifts, 8 till 8, or in the daytime or 8 to 8 at night time, with various things. They were given a little bit of a higher pay. They got a 20% high risk loading, which is our hospital authority initiative. Hospital authority, we call it the same as your National Health Service. Just to kind of fill you in, our health service here is very, very similar to the UK. It's in fact kind of really based on the UK system to some extent. It's a public health system which is free at the point of care, obviously paid for with taxes and so on. And yeah, oh sorry, the quarantine was 7 days actually afterwards, not 14 days, I'm sorry. So well, like others, we worked on what we're going to do in terms of trying to develop protocols for the highest risk activities, and obviously the very highest risk activity is airway management, both initiating airway management and withdrawing airway management. Both of these are high risk, and one of the doctors in Prince of Wales Hospital, Albert Chan, he's prepared this very nice little infographic to help remind people what to do. As you say, sort of self-explanatory. You will get a copy of this lecture at the end, I'm sure, and you can have a look at that in a little bit more detail. So This is his before, during, and after. And I think this type of thing has really been quite helpful. There've been a lot of guidelines coming out. I mean, I'm actually on the editorial board of anesthesia, and we have had absolutely, like, every day we get somebody sending something in. The problem with a lot of them is that they're not really evidence-based. You're kind of trying to guess or anticipate what is likely to be associated with increased risk of infection transmission and avoid those things. It's very difficult to have the evidence to do it. We're interestingly, I was contacted recently, well, a few weeks ago, by an engineer at the City University who has equipment for measuring aerosols, and he's very keen for us to work with him to try to look at this in a little bit more scientifically. So that's one of our plans in the next few months. Okay, so how did the COVID kind of affect our day-to-day practice? Well, we have to update our infection control training, which we've done, and we've kind of got ongoing infection control training again, I think because of our legacy of SARS. People have to get used to wearing PPE. It's actually, I'm sure you all have had to do it. It's kind of uncomfortable, not as easy to work with all that stuff on and so on. There was recommendations that we should be doing modified rapid sequence induction. So I think the use, and we saw this interestingly in SARS as well. Before SARS, not many people in our department used rocuronium, but it really shot up during SARS. And so, you know, it's kind of popular. I don't actually really like it because I find it's a relatively unpredictable drug. But of course, if you've got Sugamidex, it's not so bad. And we do have Sugamidex now. So video laryngoscopy has become the sort of de facto way to manage tracheal intubation. There's been quite a significant increase in use of regional anesthesia, as I mentioned. We use closed suction. We don't have nebulizers. Supraglottic airways, this has been a bit contentious. I still use supraglottic airways, but others say that supraglottic airways are a risk. I don't think the evidence is very strong. I can certainly easily put in a supraglottic airway without having a patient coughing and spluttering all over the place, without much leak if you manage the pressures well and properly. Patients have to wear masks all the time. It's actually kind of a, you know, some of these things, like when you institute a guideline or a protocol, our nursing staff will absolutely religiously adhere to it. So when patients are, you know, we're told that patients have to wear masks when they're doing anything apart from actually under anesthesia itself. So the first thing they do immediately, they wake up and slap a mask on them, which is a little bit disconcerting. We use a lot of intravenous anesthesia in my hospital. We've got an interest in that area for research and development, and that's actually the only type of anesthesia I use, in fact. But there are a number of reasons why I think propofol has advantages. There's the sort of classic advantages that are irrespective of the infection control, but I think that it's actually quite useful for induction because people who use inhalational anesthesia, they tend to use drugs like propofol to induce, and then while they're waiting for the muscle relaxant and various things to take effect, they kind of end up hand ventilating patients with a volatile. You can avoid that obviously with TIVA. So we use that a lot. If they're interested in TIVA, we've produced a little textbook on this, which is designed for novices to learn a little bit more about it, available from Cambridge University Press and all good bookshops. Okay, so just show you some pictures of what we do. This is just getting patients ready to go under anesthesia. Some nurses in the background preparing things. This is an OTA and a nurse who would be assisting, in this case, one of our more senior trainees with an intubation. Then whenever we're ready and we induce, all the other staff leave the operating theatre, and we'll go ahead. Now you see the staff wearing full PPE. You can choose to wear goggles or a visor. A lot of people prefer the visor. They find the goggles difficult to wear, difficult to see with, and so on. I mean, these are patients who don't have COVID and not necessarily high risk for COVID. It's quite different if you have definitely have an index patient with temperature and so on. And yeah, just some more of these. Okay. So he's using a kind of modified rapid sequence here with rocuronium and propofol infusion, keep the patient under anesthesia. So that's fairly typical. And you can see here using video laryngoscopy. This patient was having a head and neck surgery, so she needed a nasal intubation, nasotracheal intubation, which she's doing. Okay, so all that's done. Now, this is another thing. This is a SARS legacy. So we actually, whenever we extubate patients at the end of surgery, and we've been doing this now for 17 years, we put a plastic bag over the head and over the airway with the filter on the end, and we remove the endotracheal tube or the supraglottic airway into the plastic bag at the end of surgery. Okay, this is just showing you we're doing a lot more regional techniques. So this patient, I think, was going to get brachial block. Interestingly, I don't know if the sharp-eyed will notice that although they obviously put a mask on him, you can see that he actually has tracheostomy. So I think the mask is really not needed. But anyway, it's just to show you that they're just completely obsessed with putting masks on patients. So I think because you guys are interested in the whole concept of evidence-based perioperative medicine, you know that anesthesia can make a difference to perioperative mortality, and that's why we're here, and that's what we're learning about. But I think that essentially the advent of this infection has had little, for us anyway, and I'm not sure, obviously things may be a bit different for you, but if you look at the various aspects of enhanced recovery as an example, and obviously that's not the whole perioperative medicine thing, but it's an important component. Looking at preoperative, intraoperative, postoperative care, it's not had an awful lot of impact on what we're doing. We're pretty much doing very much similar things. I think probably the one thing would be we'd be using less supraglottic airways. I use supraglottic airways a lot in my practice, but probably in Hong Kong, I would say probably only about 20% of general anesthetics, the doctors here use supraglottic airways as opposed to nearly 60% in the UK. There's a lot of advantages, fast placement, don't need the laryngoscope, less hemodynamic changes. These ones I've highlighted in red, I think, are the ones that, in fact, could be useful in patients who have an infection risk in some ways, less coughing, bucking, and so on. With removal of the device, it can be difficult to extubate a patient with a ET tube without coughing or dispersing aerosol. Better preservation of laryngeal competence after the surgery, less laryngeal trauma. So I think, it's a risk versus benefit issue. I've continued to use supraglottic airways, but others have kind of basically avoided them. And you can see there's a whole host of different devices. Now, I promised at the end, just to lighten things up a little bit, I would come back to the Twitter in chief. And I don't know if you remember, going back to about April, he's come up with all sorts of wonderful ideas about how to manage this terrible infection. And one of his more innovative ones was the use of bleach and ultraviolet light to treat it. Now, this actually coincided with me receiving I think any of you who've ever published a paper anywhere will get these kind of emails, at least one a day. I usually get about 5 or 6, asking you to submit a paper to some journal. Could be anything. In this case, it's pharmacy and drug science, sometimes engineering journals, computer journals, all sorts of things. So they pretend that they know about your research and so on, and they want you to. These are basically predatory journals, open access journals. So they asked me, would I do that? So I said, yeah, this would be a great pleasure for me to submit my work to your journal and pay to have it published. It's obviously a very prestigious scientific forum. What are your submission and account details? So they very quickly got back to me about that within the same day, interestingly, thanking me for my positivity and that they had an article processing charge of about nearly £1,000. So explaining how to go about that. So I said to him, I've got an interesting article on the use of bleach injection, ultraviolet light for the treatment of COVID-19. Would this be of interest, or has it already been covered by others? Knowing that the American president had covered it, and then it's subsequently been covered by the Sun newspaper. So most people have got to know about it. If they're going to read any journal, they've got to read the Sun newspaper. And they told me the topic wasn't covered. And in fact, I could go ahead to publish that if they thought that was very interesting. So needless to say, I just left it at that. And it's just a warning for you if you ever get involved with open access journals. And that's it. So I'm happy to take any questions, comments. Thanks very much.
Thank you, Prof. Irwin. That's a really interesting talk, and I was particularly interested by the changes or your change in practice that you've experienced after your Hong Kong's first exposure to SARS 17 years ago, and how that's shaped your response to COVID-19. Hopefully, in the UK, having had our first experience of the first wave of COVID, it's quite reassuring to see that in Hong Kong you've learned from that experience, and it's shaped your further exposures to pandemics or surges, how the UK might also respond to what we're looking at, a second wave. I'm going to hand over to Katie, who's hopefully got some questions, if you're happy to take them. Katie,
I think just on that point, because maybe it sort of reinforced that a little bit, because you know, I think it's not just the medical and the healthcare experience with that. I think it was the community experience as well. So, for example, once we'd kind of heard a little bit about what was happening in China, if you went on the underground railway system or public transport, you would see everybody wearing masks, like straight away. And my daughter, my eldest daughter, was living in London at that time, and she told me, you know, she was in the London Underground, even though there was news of this coming out, nobody seemed to be in the least bit bothered about it. And I actually was in, I think it was in Brussels at the end of February, beginning of March, and it was the same there. Nobody seemed to have any care. But I don't mean that they didn't care, but I guess they don't really think about what the potential impact of this was. Whereas with us having seen all that before, it kind of instilled a fear, if you like, about what the potential was if it really took off.
Indeed, and I wonder how much of that is a cultural difference in terms of, particularly in the East, people have tended to wear masks for a number of years, and we don't see that so much here in Europe, and whether we will see that a lasting effect in the years to come. But I fear I'm digressing. Katie, did you have anything else to ask Prof. Irwin from our attendees?
Yeah, so thank you. We've had a couple of questions come through. I think for the interest of time, we'll probably only have time for one of them. But we have a question from Vicky Ogden for Professor Irwin, which is asking about the practice in theatres. So Vicky said, are filters placed at the inspiratory and expiratory valve when you're disconnecting from the anaesthetic machine? I think she's talking about the part where you put the plastic bag over the head. And then also specifically asking, in the UK, we've been kicking everyone out of theatres, so including all of the kit, sutures, trolleys for airway manoeuvres in non-elective patients, and getting all of the staff out of theatre as well. So it's just the anaesthetic team exposed potentially to the AGP. Is that something that you're also doing in your practice?
Yes, the plastic bag thing I just show you because that was something that we've done. That was before the current COVID. It's something that's been done, ever since we had SARS. And I think she's obviously right about placing the filters is very important, where they're put and so on. In terms of the staff in the operating room, we ask all of the staff to leave before the airway maneuver takes place. It's interesting that you also remove all of the using equipment and so on. I'd like to ask actually how long you allow before they come back in, because it's something that I feel we kind of let the staff back in pretty much straight away afterwards. And to me, if you obviously you understand when an aerosol generation occurs, it's going to take at least 10 or 15 minutes. A couple of air changes before that would drop down to a level where the risk is going to be quite low. But this is kind of a bit of a kind of argument discussion we've had in our department, because we were told that they could go back, that the staff could come back in pretty much within about 5 minutes after the airway was secured. But I suspect that that's still not entirely safe. What's your UK practice?
Well, so I think it varies between trusts, but certainly the guidance from the government has just changed in terms of green patients, so those who have been swabbed and screened and then self-isolated before their elective surgery. So just in the last week, that's gone back to kind of normal practice with standard PPE rather than enhanced PPE. But prior to that, and in emergency cases, it depends on your theatre setup. So where I work in Bristol, it's either 12 or 5 minutes, depending on the airflow. The ultra fast airflow theatres are only 5 minutes. The normal theatres are 12 minutes. But I suspect it varies between trusts. Brilliant, thank you so much.
Similar, I suppose. Yeah, but I don't know. I mean, it's just interesting because as I say, we've had some discussions with an engineer from another university, and he said that there are good evidence that aerosols could be even hanging around a lot longer than that, even with fast air changes. So I don't know.
Thank you very much. I think we'll probably draw close to the questions there, and I will let Aaron continue. Thank you.
Great, very much. Thank you, and thank you, Prof. Irwin, for giving up your Saturday evening to give your really interesting talk to us. We're now going to cross over to Prof. Tim Cook, who is going to talk to us about productivity problems in the post-COVID era. And Prof. Cook is a consultant in anaesthesia and intensive care at Royal United Hospital in Bath. He's also been the chair of the National Audit Projects, or the NAP projects, at the Royal College of Anaesthetists, and he's also a college advisor on airway. He's also been the Mackintosh Professor of Anaesthesia, and I'm going to hand over to Prof. Cook. Thank you.
Hi, Aaron. I've got two screens. Which can you see? Can you see just this slide or the slide and the next slide?
We can see this slide and the next slide.
Okay, so we do that. You can just see the slide now, can you?
Yeah, that's correct.
Good. Okay, cool. Delighted to hear my talk. Which is always a pleasure. Always insightful. And it's a pleasure to be here. And thanks to Aaron and Johnny and Katie and Charlie, I think, who I've liaised with. I'm going to try and stick to my about 22 minutes. See how we go. So I was asked to talk about, I think, problems with productivity. I've called it efficiency challenges instead. And I'm going to rattle through some slides and some information quite quickly. Slide advance was no, it's right. So, okay. So first to say that there is a lot of information on the hub, the anaesthesia hub, which is at the website that you can see, which is a combination of the Intensive Care Society, FICM, the Association of Anaesthetists and College, and there's clinical guidance on that. And there's a section specifically on planned surgery. There are various sections. It's a section specifically on planned surgery. Sorry, one of my screens is going to be odd, so I'm slightly struggling. And within that, there are 4 documents, which I'm not going to go through, but they're all specifically about restarting surgery and trying to make things as efficient as possible. I would highlight down here to the right the aerosol clearance times, or the fallow times, or the viral removal times. The just picking up on that discussion earlier about, it's believed, and if you try and look for the reference point, it's really difficult to find it, but about 63% of air is cleared by each air clearance, or of aerosols are thought to be cleared. I can't find any data to support that, only theoretical calculations. So that after 2 air exchanges, you're down to about 16% of the original aerosol content, and after 5 ACTs, you're down to less than 1%. So most people recommend 5 air exchanges now. So there's a massive backlog of cases. There is evidence of harm, and it is time to address the backlogs. But the key is that, so for a long period of time, we stopped patients coming into hospital. I'm going to talk predominantly about the UK. We stopped patients coming into hospitals because it was considered too dangerous for them, and that there was going to be, the hospitals were full of COVID patients. That situation has obviously changed over the summer, but it remains dangerous for patients to come into hospitals, and I'm going to talk in some length about that. So it's dangerous for patients if they come into hospitals brewing COVID, because they can infect other patients and staff. It's dangerous for them because if they have surgery while they have COVID, the mortality rates are really quite high, irrespective of the size of the surgery, irrespective of the type of anaesthesia. It's around about 30% from COVID surgery, which I suspect is an overestimate. I suspect we'll bring that down, but it's not a good thing. There are more studies coming out that come out with roughly the same figures, so it is a problem. And there's a risk of patients being infected by other patients or from other staff. So, sorry, one of my slides has gone, one of my screens has gone very strange, so my set of slides looks very odd to me. So in terms of the risk of harm to patients or staff, you have to be exposed to the virus, and then the degree to which you are harmed, and that is proximity and duration of exposure, the degree to which you are harmed will depend on your own personal characteristics. Of course, most patients are more at risk than most staff, but that's not always the case. And then in order to decrease that environmental exposure, we need a degree of mitigation. And the factors that affect the individual's risk of harm from COVID if they've got it are age, and age. There are minor impacts from ethnicity, sex, and comorbidities, but really it's all about age, with the risk of mortality increasing from COVID increasing 12% every year, or 10-fold every generation. Throughout the pandemic, we stopped surgery, essentially, apart from a little bit, maybe 50% of cancer surgery, which we weren't probably doing in April. Patients who were coming to hospital were having 14 days self-isolation and 1 or 2 PCR tests and had to be asymptomatic and screened. We're using airborne PPE for all general anaesthetics and for most surgery. And of course, during that time, the number of patients being admitted has dribbled down to almost nothing. And that's why we did this. The surgeons have prioritised which operations should be done. They've got a very sensible series of charts as to what the priorities are within each operation. I was speaking to the orthopaedic surgeons earlier this week, and just to say that this is the sort of surgery that they have said can wait 3 weeks, let's say 3 months. So that's avascular necrosis with patients going off their legs, revision surgery for impending fracture of major hip joints, sarcoma with metastases, and more than 3 months, all arthroplasties, all metal removal, all hand and upper surgery. And of course, the delay has already been about 5 months. So all these cases should have been done. So we are in a real stick in terms of catching up. And there are various ways that this graph is presented. So we have the first wave, direct deaths due to the pandemic, followed by second waves, which are either due to the second wave of the virus, but also to the impact on different types of surgery. And the cardiologists present it in this way. SAGE, so that's the Scientific Advisory Group for Emergencies, it's a UK government advisory group, have looked at have tried to balance this this risk of harm from closing down the country against the risk of harm from keeping things open and the consequences of direct deaths from the pandemic. And I think this is quite an interesting report. They've tracked as many will have seen, the deaths that have occurred directly, so the excess of deaths that have occurred throughout the UK, and you'll see the red line that this absolutely definitely deaths that are occurring from non-COVID causes. There's been an excess of deaths during the pandemic or during the first surge as a result of that. The more we locked down, the greater that red line will increase. And when they've summarized this data, if you focus on the pink area in the charts, what they've looked at is, so the more you lock down, the smaller the blue part of the first bar will be. But the greater the impact on the greater the rise in the orange sections in the later years and during people's lifetime will be, as there is greater impact from lockdown on subsequent mortality. The pink represents death and delay from non-elective allergen. Let's say it again. The delay from non-urgent elective care, and it's deemed to be a relatively small part of the morbidity. So while it is important to restart surgery, in terms of national health and well-being and survival, it's probably not as important as probably other parts of healthcare. This is made on the assumption that we have this sort of V-shaped recovery to our economy. We're expecting 10% unemployment throughout the country in the next couple of weeks. We're currently running at about 4%. And so if the economic burden of lockdown and consequences of lockdown is greater, then those impacts on that orange and pink section of the last graph will probably be greater. So let's get through that. So we have this balance that the government has to achieve of the impact of lockdown to protect hospitals, care homes, patients and staff, to save lives directly, against the consequence, the pressures to open up for the education economy and actually the whole of society. And they have an incredibly difficult job. One can comment as to how well they've done that job, but there we are. So it's tremendous that throughout the summer we've had a significantly falling number of hospital admissions from COVID, and therefore an ability to restart surgery. They haven't fallen as much as perhaps we would have hoped. So Simon Stevens at the end of July said we need to crack on. We need to get back to performing non-COVID activity while preparing for the winter demand, taking lessons and supporting staff. But to restore full cancer services and to restore the most elective activity that we can in the months before the winter. So we're now in the middle, towards the end of September. The expectation is that we'll be doing 80% of elective surgery, moving to 90% in October, which we're not. I think 11% of hospitals are doing anything approaching that. And that would not be catching up the backlog, because of course we'd be doing less than we were. The backlog would be increasing every day that we fail to achieve that. And actually, just need to talk about, before we consider the changes that have made that Katie referred to briefly, that in terms of how people are managed in hospitals now and in the UK, we need to think about viral dynamics. And this is a JAMA publication which looks at the timelines of PCR positivity in various different fluids and antibody detection. And essentially, PCRs become positive after a few days. They can stay positive for many weeks, and antibody detection probably in most people is there in week 3. This is a beautiful paper from Mythen, who's an epidemiologist in Edinburgh, and her colleagues, and it looks at I'd recommend everybody reads the paper, and it looks at the viral dynamics of SARS-CoV-2 and the other and those other MERS and SARS. And there are, I'll just go to the graph. So the summary is that incubation is roughly about 5 days, but it can be 14 days. Viral secretion, which is infectious, although we can get PCR positive tests for up to maybe 9, 10, 11, 12 weeks, In terms of viable virus, there are 9 separate studies so far that have looked at that, and none of them have shown an ability to get growable virus, reproducible virus, viable virus beyond 9 days. Most of them it's 8 or 7 days. So it seems that 9 days after beginning of symptoms, there is no virus in secretions. Probably people are not infectious. So if you put that 9 and 5 days together, that 14 days of self-isolation, which we have for people quarantining from returning to the hospital, from self-isolating when they've had contact tracing, when they've had a contact with them, 14 days is a very sensible period of time. And we can suspect that patients are really quite safe after that period of time. Most viral transmission and most infection occurs in days 0 to 5 of infection, including in asymptomatic patients. So what have NICE and PHE done? So NICE there are 2 initiatives to try and improve productivity in the theatres, starting on the 27th of July. There was a change so that patients, rather than being self-isolating for 14 days and having 1 or 2 PCR tests, they're required to have 1 PCR test up to 3 days before surgery and to self-isolate after that. Now, the rationale for this, and I accept the rationale for this, one of the problems is that if you're employed in a professional capacity and you have good working conditions, then you're probably able to take 2 weeks off work because you need to go to hospital. If you are on a 0 hours contract working for a company that has poor employment practices, you may well lose your job in those circumstances. So the belief was that people weren't doing it in certain circumstances, and essentially it's therefore been thrown away. I see no value in patients self-isolating for 3 days. NICE also emphasises that people need to wash their hands and take precautions. The whole country is supposed to be doing that. And then a little bit earlier, so latest is not the 9th of September, this was the 27th of August. PHE also changed their guidelines. And although this is about infection control and safety for people, it's got an interesting title, Remobilisation of Services. And it says that low risk, we call them green pathway, I don't really like the colours, we'll call them low risk buffers, we'll stick with low risk. These patients who are essentially NICE positive, they've been screened for they've been self-isolated for up to 3 days and had a negative PCR test, accepting of course that 20% of the 20% of cases are missed with a PCR test. Those patients need no additional precautions. So they need standard infection precautions. That means no airborne PPE during AGPs. It means no aerosol clearance times. It means no additional cleaning. This is designed to improve efficiency. Will it maintain safety? And so there we go. No additional cleaning, no additional time needed, no airborne protection PPE. And we only mentioned transmission-based precautions, so that's all those activities for patients who are suspected or known to be COVID positive. So in many ways, we have reduced the mitigation. We've reduced the mitigation and therefore increased the risk of exposure, both to staff and patients when they come to hospital. And I think we now have created, and so I think that was a reasonable thing to do when cases are extraordinarily low, but it has to be dynamic. It has to be something that can be turned off. And of course, it's taken 2 weeks for most of that to be implemented. It now probably needs to be turned off. And so the risk to staff and patients is significant. And I'll explain why that's important. So I've done about 6 talks this week, and every day they have to be changed. So see, these are some of the slides from earlier in the week. So on the 11th of September, it was clear that cases were rising. The R0 was above 1 throughout the UK, probably above 1.7 in some places. So that means exponential growth. Moving forward to what's that yesterday, we have ever increasing cases. You can start to see a blip in. So the argument was it's all happening in the young. It's lots of cases. There's more testing. Therefore, we're going to have more cases. But they're young. They won't be ill. This will help with herd immunity. They're seeing the patients, but they're not getting sick. The virus is weaker. All nonsense. So this is a graph, this is a heat map from France, and it shows that over time, although you start with the infection in relatively young people, it spreads throughout the whole community once you've got a certain amount of community spread. And that is exactly what's happened in the UK. Hospital admissions are rising in every region. There's now a hospital admission doubling time of about 8 days. Yesterday, interviewing Jeremy Farrar, I was told that it was between 5 and 7 days. So we're on a steep part. Admittedly, this is only going back to July. Cases are low, but we are in a place of hazard. So there we go. Diminishing, 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 diminishing. But unfortunately, the timing is wrong. And remember that the effect on R0 of schools opening has not yet occurred. So schools opening increases R0 by about 0.4. So it may well be above 2 in some parts of the country in 2 or 3 weeks, because the impact of school opening has not happened. So we're now at a state where we're opening up hospitals, full steam ahead with elective surgery, a maximum of 3 days self-isolation, and standard infection control. In Thameside, which is in Bolton, they've had a significant outbreak of COVID within the hospital. You remember back to Weston-super-Mare Hospital, which had to be closed because of high staff rates of infection, possibly due, and the report came out last week, suggested that 18 deaths associated with that hospital outbreak. So there are 3 sorts of epidemics in the UK. There is the community epidemic, the care home epidemic, and the hospitals. And the care homes were probably the victims of the first surge, and there is a danger, in my view, that hospitals will be sort of the seeding bed in the second surge. We know that the rate of infection amongst healthcare workers is roughly 3 or 4 times the community rate. And I'm going to jump through quite a lot of slides quite quickly just to show some of the serological surveillance that's shown there. So I will come first back to this COPE study, this COPE nosocomial study, which is quite interesting. So this was a study of patients who had acquired, essentially looking for patients who had acquired. We went around 11 hospitals, 1 in Italy, 10 in the UK, and identified patients with COVID and tried to work out where they got it. And those patients who'd had it, who acquired it more than 15 days after admission, were deemed to be hospital acquired. And the other 2 were lumped together as community acquired, those uncertain and those known to have got it before admission. And they then compared various the sort of outcomes from these patients, and they had a marked difference in terms of when they'd acquired it. At the bottom here, we see the mortality was essentially the same, very slightly higher for the community acquired. Those patients who acquired it in the hospital tended to be older, they were frailer, and they had more comorbidities. So if you accounted for those, although this mortality rate was the same, if you accounted for those, the adjusted hazard ratio of death amongst the hospital acquired group was about 0.8. So they're slightly less likely to die. So their interpretation of what the paper says is hospital acquired COVID has a lower mortality than community acquired, great. This is despite them being older and frailer, great. This must be due to early identification and better treatment, great. And that's what the BBC said. I think that's wrong. So they only looked at infections after patients have been in for 15 days. Not many patients stay in for non-COVID reasons for 15 days. So these were inevitably an old, frail group of patients. So we didn't see the patients who perhaps got it within less than 14 days, or those that went home. And so perhaps a quarter of all the cases, in fact, were hospital acquired, not 1/8. And also, you had to be a long stay to be included. So it's better to consider it as a study of hospital acquired in old and frail patients. But importantly, there's about 1 or 1.5 infections per day. And when we come to the mortality, it's really important. So all the patients who were in hospital with COVID, who've got it and come into hospital with COVID, were there because they had severe COVID. And there would be 10 or 20 or 30 patients at the same time who were not in hospital because they hadn't had it severely or they'd been asymptomatic. Those who acquired it in hospital could have had it from any severity. So one would expect the mortality to be much lower in the group that acquired in hospital, because some would be asymptomatic, some would be have very few symptoms, but only very few would be severe. And so the fact that there's similar mortality and the adjusted hazard ratio is only 0.7 is really significant. So hospital-acquired patients getting nosocomial COVID is a big problem in my view. Of course, there's also a risk to staff. We know that about 260 UK healthcare staff have died from COVID since the start. It is a risk factor for death. Anaesthetists and intensive care doctors are almost free of it. Otherwise, it affects pretty much every type of specialty, and I would say probably emergency physicians and respiratory physicians are at the greatest risk. Just going on to this serology, are hospitals at a higher risk for infection of a place of epidemics? This is the REACT-2 study from Imperial. They looked at 100,000 serology tests, and they identified that being a care home worker or a patient-facing healthcare worker increased your risk of having COVID twofold. This study of 1,000 healthcare workers from Cambridge University, excuse me, showed a couple of important things. It showed that infections occur in clusters. So these are different wards, and the number of positives that they had. You see these two red outliers where they had a cluster of cases. They were tracked down to poor practices in terms of PPE and detection of patients. So you get these in the same way as you get mini clusters in countries, you get mini clusters in towns, you get mini clusters in houses, you get mini clusters in wards. And so these were two outbreaks, and these were probably two other outbreaks which weren't quite characterized during that time. But most of these cases, so they were doing surveillance. Excuse me. So the cases that were identified, the green ones, were asymptomatic screened patients. So they only identified the staff as being infected because they were screening. These were asymptomatic patients continuing to work, and this is the common theme. Patients get it and they continue, sorry, staff get it and continue to work. Another big study, Oxford, 10,000 patients, 10,000 staff, brilliant study. And they showed that there's lots of associations that they show which are important in terms of race and types of jobs, etc. Again, they show the importance of sporadic outbreaks. They show that working in a COVID-specific area is important. Consistently, actually, what is also important to note is that having a household contact wherever. So this is mainly where the infections are spread. But also, they showed that staff working in intensive care were half as likely as medics, probably a third as likely as medics to get it. So intensive care protected. Skip past that. Oh yes, and sorry, importantly, so the antibody positivity rate was about 3-fold higher than the community rate. And there we see anaesthetists and intensivists compared to, I think this is hematology, sorry, that should have been covered. Hematology, trauma, and acute medicine. Not quite sure why those are up there. SAFER study looked at, I think, about 300 staff in UCH. Again, 200 staff in UCH, studied them for 2 months. So London was the epicenter of the UK outbreak for the first 2 months. So this is Monty would be, one of the, working in that hospital during this time. So at that time, so London has been the epicenter of the epidemic, and we think that about 15%, maybe 20% of Londoners have been infected over the course of that first surge. But in this study, 21% over a period of about 4 weeks were actively infected during that time. The vast majority of whom were asymptomatic and continuing to work. And 45%, again, 3-fold the rate of the community, was seropositive. And if we look at the types of staff, we'll see ITU were very low in terms of people becoming infected, and were quite low in terms of ranks of types of staff who had anaesthetists were not included in this, but who had some evidence of previous exposure. And finally, Birmingham, this is one reported in the news this week, Birmingham 545 health workers, and the headline in the news was that cleaners are more at risk of getting COVID than intensive care staff, and so it is. So the relative risk is twofold, but the perhaps more important fact is that within the hospital, so the incidence in the Birmingham area was about 6% during this time. So 4 times the number of staff within hospitals have infection compared to the community. So why intensivists and anaesthetists better off? I think there are a number of reasons. I think we undoubtedly have better PPE. I think we probably have better behaviours. I think we respect the virus in ways that not everybody does. We're used to working in theatres. We're used to infection control procedures. We're used to not touching people who are having operations and using PPE to protect the patient, but it's very easy to then change it to us. And I think then the other thing, we go back to that Sulik paper, is that at 9 days, probably patients, although they're PCR positive, are not secreting live virus. And therefore the infection may well have burnt down by the time the patients at 9 days are admitted to hospital and deteriorate on day 11 and need to come to ITU. So it may be that we're not dealing with the highest risk patients, and the people who are those at the front door, or those in health, so healthcare centres, GPs, people in A&E, and particularly the respiratory physicians who see them coming in off the street. So there we go. Infection. So there's also an Office for National Statistics paper which I couldn't find, which shows 4 times the rate of infection in healthcare workers compared to the community. Importantly, I just put these last slides in while Mike was talking, actually. So in terms of increasing productivity, we need to be efficient in theatre. Are AGPs actually aerosol generating? There's this paper from Tran, the systematic review around the time of SARS shows that intubation is most strongly. So people who intubate are very highly associated with getting disease transmission. SARS is a very different disease from COVID. So its peak secretion of live virus is at the time when patients are most critically ill. So they've got the most virus coming out at the time when they're intubated. That's one thing. And also, these were all retrospective observational studies with plenty of biases. And it may be that those people who were intubating or were in the room at the time of intubation were also the same people who were doing other things, such as tracheal suction and looking after patients for a prolonged period of time and being close to them, that put them at risk of infection. But the actual intubation process was not. And also North American practices for intubation are very different from UK practices in terms of use of muscle relaxants, the time taken, etc., etc., etc. Intubate COVID suggests that 10% of intubators get symptoms within 14 days. But again, is this a sort of bias by association? 2 interesting developments. So Mike was talking about perhaps working with an engineer and aerosol sampling. So a group have done this and they published in the American Journal of Respiratory and Critical Care. And they've essentially shown, to summarize it, that NIV, and so they've looked at aerosol particle generation during different modalities of oxygen delivery while patients are breathing, talking, deep breathing and coughing, and using coughing as the sort of standard. And they've actually shown that there's very little difference between those modalities. You get more aerosol with deep breathing and coughing, as you'd expect, but actually NIV and high flow reduce aerosol generation compared to oxygen delivery. So actually, rather than being high risk, they're actually probably safer. I think it's a really important paper. And then some work that I'm peripherally involved with, or partly involved with, I hope to be more involved with, is important work in Bristol where we're doing exactly what Mike has suggested, and maybe Mike and I should talk, which is what's called the aerator study, which is looking at all different modalities of oxygen delivery, and there's an anaesthesia limb. There is a paper now with anaesthesia which has looked at intubation. If you're clever, you can find it on Med Archives, but I'm not going to show you where it is. And that's looked at intubation and extubation and aerosols generated at that time. And I think it's fair to say that the data is reassuring. Mike mentions supraglottic airways, so there is guidance again on that anaesthesia, on the anaesthesia intensive care hub about that. This is an article we've written, now published in Anaesthesia, about endemic airway management. And I completely agree with Mike that there are procedures that occur during supraglottic airway insertion and removal which may be aerosol generating. I have to say they may not be. coughing is, but the others I think probably aren't. But they are deemed they're on the high risk aerosol generation list. But if you are able to insert your supraglottic airway without face mask ventilation, suction, multiple attempts, or having to intubate, it's probably low risk. It's probably low risk unless you have a leak, and you should be changing it. If you have a leak, it's low risk throughout that time. And removal similarly is low risk unless you have to do those procedures. So I think there will be quite a lot of difference between different hospitals as to who uses and doesn't use supraglottic airways. It hasn't changed my practice. So problems, not solutions. Some solutions, and I'm sorry, I appear to have overrun far more than I thought I would. So I think we need to be dynamic. So there needs to be dynamic approaches in society to reduce transmission, to give us time until we have a vaccine, because there's no other way out. That may include national lockdowns. Those are being mooted. It may include the vulnerable, particularly the elderly, having to self-protect in a way that wasn't done with lockdowns. We need to know what's happening in hospitals. We need to know whether our hospital is another Thameside, our hospital is another Weston-super-Mare, before it becomes a problem and patients die as a result of it. And we need to have rigorous in-hospital management. So separation of patients who do and don't have COVID in their pathways, evidence-based practice in theatres, and we need to improve that evidence, but that is coming. Perhaps protection of previously shielded or higher risk staff, dialing that up and dialing it down. Targeted ITU expansion that doesn't expand into anaesthesia and surgical areas unless it's absolutely essential when we've got a real major surge. And cleverer use of the independent sector, non-hospitals, and lastly the Nightingale facilities. And you'll note I don't call them Nightingale hospitals. They are not hospitals. They are space that is a pressure releasing valve. That's all. Okay, sorry to overrun. There we go. Thank you very much.
Well, thank you so much, Professor Cook. That was a really, really interesting talk, no doubt. We haven't had any formal questions, but I've got one question, which I think will be the only one in the interest of time. We've talked a lot about the kind of the risk to staff, but also the risk to patients of catching COVID during their surgical stay. And I know from the COVID surge study and some of the smaller kind of case reports and small observational studies that we think the risk to patients catching COVID during their preoperative stay or coming in with it before their operation without realizing increases their risks. Do you think there's robust enough methods currently to include in our consent process for these patients? We don't have the facts and figures to tell them what their risk of complications or death is if they catch COVID during the major surgery, but do you think it should be a routine part of our preoperative consent now?
I think it's the responsibility of the surgeons. We're seeing the vast majority of people just before surgery, particularly with the way people are being brought into hospital at the moment. Those discussions, and the shared decision making needs to happen well before patients get to hospital. And so, am I able to just show one slide?
Yep, sure. 1 second. I'll just reactivate you.
Let me.
1 second. You have it. I just asked because some of our attendees are from other specialties other than anaesthesia and intensive care. So it's just whether there isn't really enough to give solid facts and figures.
We in Bath, what my colleagues have produced something called. Can you see that?
No, not yet.
The Bath elective. Produced the Bath elective surgical triage, and we've used the COVID surge to identify patients who are at increased risk of harm if they get COVID while they're in hospital. And we've added a few, I think, which weren't in COVID, and I think we should add obesity as well. And we then use that to triage how they should self-isolate. So we direct the surgeons to do this. Is essentially, if you've got no risk factors, the surgeons, the surgeons have to do the consent to make the individual shared decision making with the patient, and then what is mandated or advised in terms of self-isolation, we then use that. I know Alex Goodwin, one of my colleagues, he says that when he sees all patients, he's currently saying, you know, you do need to know that while in hospital, you have an increased risk of getting infection and being harmed. It's really difficult to know whether, you know, just before you go into anaesthesia, that's the right time to tell somebody that. And of course, he's telling them on the ward. So we have a responsibility to inform, we have a responsibility not to frighten, and really the responsibility or the action should have been taken well upstream. As the surge increases, it will become more and more of a problem and more of a responsibility to ensure that we're doing the right thing. That's all I can really say on that.
Brilliant, thank you so much. In the interest of time, I'm sure there's lots of other questions, but I'll hand back to Aaron to introduce our next speaker. But thank you very much.
My apologies for overrunning, but lovely to see you all.
Thank you very much, Professor Cook. We're now going to hand straight over to Prof. Mythen, who really needs no introduction. Prof. Mythen is the Smith's Medical Professor of Anaesthesia and Critical Care at UCL. He's also the Adjunct Professor at the Department of Anesthesiology at Duke University in the US. And Prof. Mythen's been the founding director of TRIPOM International. He's also the co-founder and editor-in-chief for Top Med Talks, and I'm sure you're very familiar with his voice from those very informative podcasts. I'm now going to hand over to Prof. Mythen.
Brilliant, thanks very much, and congratulations to TRIPOM for organising this, putting it together. I think we're down to the last 8 minutes, so I'll do my best to give my presentation and try and get us a little bit back on time, but I can't promise to do it in 8 minutes. It's not a very COVID talk, apart from the fact that I think the messages I've got are highly pertinent to both what we've been doing in ITU, but more specifically related to the rebooting of elective surgery. I've had COVID-19 fairly early on in the journey at UCH. I contracted COVID-19. I don't recommend it to anyone if anyone has not experienced it yet. If you are susceptible, it's really quite unpleasant. Some potential conflicts of interest there, some disclosures. I don't think any of them are that pertinent to this talk, apart from things you've heard about Top Med Talk and EdPom. So as has been alluded to in the 2 previous talks, we're trying to reboot elective surgery, and in doing that, we're going to be adhering to our enhanced recovery principles. And right at the heart of that is this target set within the PQIP annual report of 2017-18. If we're going to be as efficient as possible in delivery, particularly of our cancer surgery, we should be implementing all enhanced recovery principles and be trying to getting all of our patients drinking, eating and mobilizing within 24 hours of all forms of major surgery. Completely tangible target. I'm sure you're all achieving it in all of your organizations. This iconic picture taken at UCH almost 10 years ago now of a patient who's had 4 hours of GA with moderate blood loss, been extubated, and an hour later has finished their NHS lunchbox with an orange yogurt to sandwich and on their second cup of tea. They'll be mobilized shortly afterwards and should be home within 48 to 72 hours. And we all accept that's our new norm. That should be our standard. Now, in order to achieve that, you have to have a functioning GI tract. Now, why do I mention that? Well, the commonest complication in our literature base that keeps people in hospital postoperatively is GI tract dysfunction. This is a relatively recent publication from the Perioperative Quality Initiative, POQI, a different organization, where you can find a series of publications online. Someone's clinking their cutlery. If you don't mind muting, it would be greatly appreciated. POQI.org, you'll find these publications, and within it is this I-FEED score. So if we look across the top, patients after elective major surgery should have a normal intake. They shouldn't be feeling nauseated or vomiting. They should have a nice soft tummy, and they should be up and about and going straight away. If you go down to the red, this is the other end of the spectrum, patients who are completely intolerant to intake, persistently nauseated, throwing up with a distended tympanic belly, and that goes on for 3 days. They get a nasogastric tube back down. They've got what we used to call an ileus, and we now call postoperative GI tract dysfunction. Now, that's relatively uncommon in our hospitals. Some places it's disturbingly more common than others. But the bit in the middle is the most commonly reported major postoperative morbidity that delays hospital stay. That is the not quite right patient who is still not on a full diet, still feels a bit queasy, has the occasional vomit, and has a slightly distended tummy. That is what we're trying to avoid, and it is completely avoidable. Here's a picture of the GI tract, the lining of the GI tract. It's an electron micrograph taken from a series of studies that I did decades ago. So a very beautiful little structure that lines our GI tract that allows us to absorb nutrients and exchange water and electrolytes. It's a sensitive beast. So if you look at the anatomy of it, the blood supply, it has a countercurrent blood supply, which is great for absorption. But it also means that it's highly susceptible to reduced oxygen levels and or flow and or blood volume. So even in health, right at the moment as you sit there now, the tip of your microvillus is relatively hypoxic. That triggers apoptosis, so programmed cell death, and turns those cells over. Same thing happens in your hair, same things happens in your nails. But in this particular situation here, the challenge you have is if that apoptosis triggers over to necrosis, you start to lose the integrity of the lining of your GI tract, and putting it crudely, you leak the contents of your GI tract into your bloodstream and into your lymphatics, and that's not nice. It's a piece of ancient history now, which I think is quite important for us to, when we think about looking after the gut perioperatively, we should remind ourselves that prior to 1990, we didn't really have any proper antiemetics. In the development of the modern antiemetics, this example is the development of ondansetron, published in the New England Journal of Medicine in March 1990. In this animal model, they've actually caused gut damage by giving chemotherapy. In the principal example, it was by giving cisplatin to a ferret. That caused damage of the gut, which caused an outpouring from the enterochromaffin cells of 5-HT3, of serotonin. And 90% of your serotonin is in your GI tract. That latches on to specific 5-HT3 receptors in your GI tract. That then travels up the afferent vagal nerves into your chemoreceptor trigger zone, and that's what makes you feel sick. So if you cause necrosis of the lining of the GI tract, you get intractable nausea followed by intractable vomiting, and if you're very unlucky, you go on to get a full ileus. So here's an electron micrograph, again taken by me and colleagues in the last century, showing on the left-hand side a healthy microvillus, and on the right-hand side what the microvillus would look like if you gave cisplatin, for example. So it would cause necrosis of the tip of the microvillus. That microvillus would now mean that you now have a leaky gut. You also have a dying gut, and 5-HT3 is pouring out. Here's a review article, very beautiful cartoons from the New England Journal of Medicine. It's from 12 years ago, and it's reiterating the development of our subsequent generations of 5-HT3 receptor antagonists. Here in this cartoon, they show that 5-HT3 is pouring out from those crypts in the GI tract, latching specifically onto the 5-HT3 receptors, traveling up the vagal afferents and making you sick. Now at the bottom it says this mechanism explains why their clinical use is limited to situations that produce vagal stimulation, e.g. surgery and chemotherapy. Now you might ask, why does surgery produce vagal stimulation, and is that what they really mean? If you're having a hip replacement, do you get vagal stimulation that makes you feel sick? Here's an article published by myself and TJ Gann in 1995 when I was working at Duke University Medical Center with TJ. We were looking at a laboratory animal model, and we were creating gut underperfusion with hypovolemia, and then measuring the serotonin levels in the lining of the GI tract. And that's the beginning of the hypothesis that underperfusion of the gut is one of the principal drivers of serious postoperative nausea and vomiting. And it's usually iatrogenic, and it's usually completely avoidable, which is perhaps why some centers have almost no PONV postoperatively, and other centers report disturbingly high levels. Why do I say that? Well, our attitudes to the management of the blood volume, circulating blood volume, varies enormously. We don't have time to go into the literature now, but you will know that it is random chaos, which has been written about quite a lot in the last decade or so. Now, if you're watching, we know it's not you. It never is. It's never anybody in the room. It's just the others. But in reality, when we look at observational data, about 1 in 10 of us is very good at managing blood volume. 1 in 10 of us is frankly a dangerous weapon, and most of us are pretty average unless we use more advanced hemodynamic monitoring to help us. Why is that so? Well, we must remind ourselves when we look at the heart, lungs, splanchnic circulation that we're pressure sensitive and servo controlled. So we're trying relentlessly to maintain cardiac volumes and output, which means that we're always trying to maintain pressure. Sorry to insult you with these very simple concepts, but here's 5 litres of intravascular blood volume made up of plasma and blood. We're going to measure the pressure in it. We'll call that our mean arterial pressure for argument's sake. It would make life very easy if it was a rigid walled container and when volume went down by 25%, pressure went down by 25%. As you know very well, we can compensate for a 40% blood loss in healthy humans. If we're lying flat on our back, we can cope with 40% blood loss without a change in pressure because we squeeze the blood supply out of our so-called unstressed volume into our stressed volume. So if you do your volume and fluid management based on pressure, you basically ain't got a clue. Here is a cartoon showing euvolemia and hypovolemia, the distribution of blood flow through the various different organs on the left-hand side. And then just a hint of hypovolemia, it's the splanchnic organs that are sacrificed initially. Now, to start with, you've got about 250 mils in a 70 kilogram person of blood that you can give up without a serious compromising of blood supply. We know we can donate a unit of blood, which is more than that, for example. And if we then have a bit of a rest and drink, we reformulate some blood and it's okay. But during that period, we do actually have loss of blood supply to some of the microcirculation of, for example, the GI tract. It goes down first, followed by the kidneys, the muscle, the skin, the bones, and the fat. So this image I showed you was from the work that I did in the laboratory, and it wasn't actually cisplatin that caused that necrosis and that pouring out of 5-HT3. It was mild hypovolemia that caused it. So mild hypovolemia causes a loss of blood supply to the lining of the GI tract, an outpouring of 5-HT3, and persistent postoperative nausea, vomiting, and if you're unlucky, an ileus. So here's an image from a laboratory. This is Simon Davis from York and one of our medical students. This medical student's doing an intercalated physiology degree at UCL, and we're in the large animal laboratory. This is an anesthetized pig. I won't go through all the details now. The manuscript's under review at the moment. The abstract will be out, will be shown at the Dingle meeting very shortly. So the medical student's about to introduce an SDF camera into the lumen of the GI tract so we can look at the microcirculation during a period of hemorrhage, but also during a period of the administration of vasopressors. Why are we doing this particular experiment? Because it's become very fashionable for people to run vasopressor infusions to keep blood pressure up, but not necessarily always addressing volume status before they do it. And in this experiment, we were demonstrating, I hope you can see the video, okay, we were demonstrating the catastrophic effects, visualizing the catastrophic effects of squeezing a slightly empty, in this case, porcine model, but I can tell you from previous experience that similar things happen in humans. So I hope this video is coming across okay. They usually don't come over that well through these secondary transmissions on these type of webinars, but we do run other special virtual laboratory sessions that you can come and join us at our various different EdPOM meetings where we can show you the high quality images. But this is a healthy lumen of the GI tract. I hope you can see the fingers there and the continuous flow of the microcirculation in health. What we're looking at here now is the same microcirculation, but following about 500 mils of blood loss. So you're seeing a blanching of the blood supply in the microvillus. In some places it's become static, in some places it's become pulsatile and reversing. This is PON-V in action. So if you leave this there in a human, and I say this human work has been done by myself and others in thousands of patients over the decades, this is creating that persistent postoperative nausea and vomiting and can go on to produce ileus and more serious complications. As I said, all very well described in the literature. Here's a sort of unifying algorithm of what has been confirmed happens. If, for example, you're hypovolemic, you get release of endogenous vasoconstrictors that cause selective splanchnic ischemia. That can result in gut mucosal ischemia. That will result in gut mucosal barrier disruption, translocation of bowel contents, excessive activation of inflammatory pathways, which can go on to produce multiple organ dysfunction syndrome. I said we don't have time in this talk to go through it, but that is extremely well described in thousands of patients and very many publications over the previous decades. What you see much more commonly is postoperative nausea and vomiting and ileus. And in some places, in some centres, with the exception of a few procedures, PONV and ileus just does not happen because the way the patients are looked after. Now, to close, what can we do about that? Well, the first thing is not to be restrictive with your fluid management. So we know with the RELIEF trial, for example, that wherever that idea of running patients dry came from, it has no physiological rationale, it has no therapeutic benefit, and now in the largest trial ever conducted in this space of 3,000 patients, a higher rate of, in sometimes situations, quite serious acute kidney injury was seen in patients with a zero balance. So if you haven't already, please go back to giving your sort of 10 ml per kilo bolus at the beginning of a case. And if you're going to be a guesser, if you're not going to use more advanced hemodynamic monitoring, please guess moist. So your target should be about +1 to +2 litres at the end of the case. And most of the guidelines have been updated now to echo that. We're also trying to defend blood pressure now, because there's been a series of publications and a series of guidelines that have come out. This is an example from the Cleveland Clinic showing that your probability of having myocardial infarction or acute kidney injury rises if your MAP drops below 65, irrespective of your baseline blood pressure. And therefore, the current guidance suggests, this from the BJA, for example, that we should be defending the MAP to keep it above 65. Another huge study about to come out that replicates that and suggesting actually some of the thresholds may be a little bit higher. So what do we do about that? Well, you know, many of us now are running vasoactive, many were for many years, but much more commonly seeing the running of infusions of vasoactive medications. In this example here, peripheral dilute norepinephrine being run to maintain a MAP either above the magic number of 65 or within a percentage of baseline. This particular example, the Foutier study, multi-center study from France, where they gave a peripheral dilute norepinephrine infusion to keep the systolic within a percentage of baseline, and outcomes appeared to be much better. But please do read this study closely if you're going to practice this way. Everybody had cardiac output measured, because that's a standard in France, according to the paper. And everybody prior to having their vasopressor started was volume loaded to optimize stroke volume. So this was volume loading, flow optimization, and then and only then a vasopressor to defend pressure. So we are seeing a greater use of vasopressors. Peripheral dilute norepinephrine or phenylephrine is increasingly being used. You may or may not in your institution yet be allowed to use peripheral dilute norepinephrine, but very many centers you can. But the really important thing is to please fill before you squeeze. That's sort of pulled together in this trial here, the Fedora trial. This is a Spanish multi-center trial. I'm lucky to be a co-author on it, looking at the effect of goal-directed hemodynamic therapy on postoperative complications in low to moderate risk patients. So it's a good few hundred patients, multi-center Spanish. They used this very simple algorithm. They measured stroke volume, cardiac index, and mean arterial pressure. They gave their standard fluid boluses. They chose 250 mils. They optimized stroke volume. And then they ask a simple question, is the MAP greater than 65 or not? If the MAP was greater than 65 and the cardiac index was greater than 2.5, nothing to see here, just carry on. If the MAP was less than 65, but the index was above this arbitrarily chosen number with some rationale behind it, then they started a vasopressor. There's a typo on the blue box on the right-hand side. If the MAP was less than 65 and the index was less than 2.5, they'd start an inotrope. And the inotrope is very, very rarely started. And that's drawn together in this, which is a hemodynamic framework published in POCI. And I think this is probably what we all do every day of the week. We ask, is there a clinical problem? We combine the available information with our advanced hemodynamic monitoring, which should be routinely available in every NHS hospital. We don't regard fluid responsiveness as a problem in its own right. We try and work out what's causing the problem, anaesthetic, blood loss, etc. We use our advanced monitoring, but most importantly, we use our brains. And then combining that information, we say, did they need preload adjusted, afterload adjusted, or contractility? Most of the time, it's a bit of volume. Some of the time, it's a bit of squeeze, and very occasionally, it's an inotrope for those patients are usually pre-identified as being high risk. So to conclude, The GI tract dysfunction is the commonest postoperative complication. The GI tract is very sensitive to hypovolemia. Using venous vasoconstrictors to defend MAP is crisis management. That may be a necessary transient intervention. And we should treat volume, then flow, then pressure, optimizing stroke volume to be about 2 litres positive at the end of a major elective case. That's now evidence-based, and try and keep the MAP above 65. Now, all of this was major in play in the first few weeks of seeing the COVID-19 surge. And sadly, it took a few weeks for people to work out that just because it was an acute lung injury, it's not in a patient's best interest to be run dry and over squeezed. And we saw a lot of probably iatrogenic AKI until everyone backed off and just did the simple right thing. Don't overthink it. Don't be too clever. Airway, breathing, circulation, intubation, ventilation, 8 mils per kilo, 8 of PEEP. Give some fluid until you get the stroke volume to the right place, and then hope everything gets better after that. Here's 4 recent publications that pulls all that together. Top left-hand side is the ASA POCI publication on the perioperative fluid management in enhanced recovery. Bottom left is a much more recent publication from POCI about fluid responsiveness and venous capacitance. Top right is the annual update from the International Fluid Academy. And the bottom right is a greater details about postoperative GI tract dysfunction. But if you look after your patients properly, if you fill them up well, if you maintain volume, flow and pressure, you won't need to read that because you won't have any patients who get ileus postoperatively. Thanks for listening.
Brilliant. Thank you so much, Professor Mythen, for that talk. A question that I have is that we know from the evidence that having hemodynamic monitoring gives better outcomes for our patients perioperatively. However, it's still not commonplace to see hemodynamic monitoring in every single trust. What do you think are the barriers to trusts bringing in the kit and allowing the perioperative team to use them? And do you think COVID has had any impact on the momentum in getting this equipment available?
So it is supposed to be a national standard that every trust should have cardiac output monitoring available, and we seemed to get there at one stage back in 2008, 2009. And it is a nice recommendation that that such monitoring should be applied to patients at a particular risk level. What tends to happen is as we get budgetary squeezes, people look around for disposables to not order. Then people find it hard to get the monitoring, then they forget they've got the boxes, and they forget how to turn it on and forget how to use it, and it's another downward cycle of misery and despair. So I would suggest you don't tolerate the fact that somebody says to you the monitors aren't available and the disposables aren't available, because they should be. It's a national standard. Brilliant,
thank you so much. And I'll just check if there's other questions. Oh, there is a question from Jeff Preek that says, should we be telling people to actively drink water operatively?
Preoperatively, yes, I think we should. And I think it works better if you sort of prescribe it. Because I think if you say to somebody, try and do the right thing, it's much harder than if you say, there's X amount of fluid, I want you to try and get that down you before we get to this period before surgery, and then I will continue to give you an appropriate amount or allow you to have an appropriate amount until we go to surgery. Now, you will all know that whether we should have NPO for the majority of our patients at all is an area of hot debate. PEDS have gone to no NPO for clear fluids, and the debate which has been proposed in the British Journal of Anaesthesia in an editorial in the last few months is that actually we should drop it for adults as well, because you're better off actively drinking clear fluids than you are being starved.
Brilliant, thank you so much. I think in the interest of time, I know we've overrun a little bit, but I think it was really worth hearing your full talk, Professor Mythen, so thank you so much. And I'd like to also thank our other speakers, Professor Irwin and Professor Cook, for their valued time on our Saturday morning and other people's Saturday afternoon. So thank you so much, all of you. I'll now just hand back to Aaron to close the session.
Thank you.
And And thank you to all our speakers for giving up their time. It's been a truly insightful morning. We're very grateful to Professors Irwin, Cook and Mythen for giving up their time to share their wealth of experience and knowledge with us. It's been a really interesting morning. Just a little promo for next week. We're going to be moving further along our perioperative journey, covering post-operative management. Our speakers include Professor Rupert Pearse from the Royal London, and that QR code gives you a link to register for next week's session. And you can also type in that link bit.ly/TRIPOM3 to register for the third webinar in our series. Don't forget to answer the feedback, which will come to you in an email tomorrow. And if you complete the feedback, you'll get a certificate to confirm that you attended today. Thank you very much, and I hope you have a great Saturday. The recording will be available after you complete the feedback and you get your certificate.